because we got to catch up a little bit. We have important satellite sessions during the lunch break. Ido is suggesting that everybody use the hashtag PERT 2016, P-E-R-T 2016, if you're a PERTer, a tweeter. All right, so let's talk about the real world again, because that's actually what I was sort of referring to when I addressed our incredible panel. That is an amazing panel. Next year's meeting, we're going to expand. We're going to have probably allow for an hour discussion, because I think we could go on for at least an hour. So what about this 37-year-old male recovering from knee surgery who, after defecating, feels dizzy and presents with a large pulmonary embolism and a PO2 of 80, resuscitated with oxygen and fluid and transferred to our place where he has clot in transit at MGH, and you can see his coronal view of large pulmonary embolism. And the question is, in that kind of a case, what do you do? How do you make a decision, and who makes the decision, and on what basis do they do that? Or in this 54-year-old guy who presents with sudden onset of shortness of breath and left pleuritic chest pain, has a heart rate of 112, that's probably the best marker, respiratory rate 22, and his SAT's 89%, and he has a large pulmonary embolism, large volume pulmonary embolism, not nearly as unstable as the other patient. Troponin at 1.5, BNP at 3,400, and his echo shows dilated RV and a large high RV to LV ratio. So what to do, and who makes these decisions on a day-to-day basis in your emergency rooms? You have all these alternatives, anticoagulation alone on the left, and which agent do you use? And on the right side, you have thrombolysis or mechanical clot removal or surgery. And we have Tor Sunt's going to talk this afternoon about the surgical applications. How do we decide which therapy to give, apply in a given patient? Well, I would submit that less than 5% of patients with PE receive advanced therapies, and maybe with good reason in most cases. But I think there are some who would benefit, and I sort of described that patient of mine who clearly benefited from it. And by the way, she made that decision. She participated in a phone call, a go-to-meeting call, where she actually weighed in and said, I want this. I want to take that chance. So why don't people make the decision to sort of move forward? There's a fear of potential of complications, bleeding primarily, and frankly, there are also systems issues. The inability to respond rapidly to a situation like that in the ED, and there's a paralysis in decision-making that occurs as a result. So what do we do? In the setting of this about 3.5 years ago at our place, we got together and said, well, we were a little after you, Nils. You started in 2010. We started in 2012. We said the strategies are all over the map here at Mass General. If you're a patient presenting with a PE in the ED or on the orthopedics floor or on the neurosurgical floor or medicine, there's no standard algorithm. Everybody gets whatever the responding clinician decides based on their interpretation of the guidelines and their interpretation of the patient's desires. There's no single team or clearinghouse and no centralized location for that care. And we weren't evaluating the results in a systemic way. So we decided that we need to change this, and we created this thing called the PERT, the Pulmonary Embolism Response Team. I'll give Rich Chanik the nod for having come up with the name. And our mission was to advance the diagnosis, treatment, and outcomes of our patients with PE, and to improve the patient outcomes using a multidisciplinary, collaborative, team-based approach in an urgent consultative way, which is different than most places do. It's a little bit like cancer. Well, cancer centers, you get together and the oncologist and the surgeon and the radiation oncologist, they talk, but it's not urgent consultation. So we had to figure out how to make that happen in an urgent way so we can make decisions in a rapid way about patients. It's also different than acute MI, for example, where everybody kind of knows what the guidelines say and there's only one specialty making the decision. Well, here we're talking about multiple specialties. So how do we make that happen? How do we change this chaos, which used to exist when a patient presented with pulmonary embolism at Mass General, to something like this, which is pretty cohesive and pretty unified? So what we did was we created a multidisciplinary collaborative team approach. We sat around a table, about 7 or 8 disciplines, and said, how are we going to do this together? And all have input in a rapid way into what happens with the patients. Well, this is about 3 years ago with the core of the PERT team, or a few of them. It was probably double at that time. Now it's about 4 times that size. And the objectives of the PERT team were to respond expeditiously to treat these patients with massive and submassive large pulmonary emboli, not the small subsegmental things, to provide those patients the best therapeutic options for that patient, to leverage the input of a multidisciplinary team of experts and coordinate the care amongst all the services involved with PE, and to develop protocols for the full range of therapies available, to collect data on how the patients were presenting and how we were treating them and were we effective. We saw this as a very big unmet clinical need, and we needed to add to the evidence base to allow the guidelines to actually reflect the next level. We set up posters all around the hospital. Call this one number if you have a patient with a large pulmonary embolism for PERT. And we developed a flow map, and what you can see here is if it's a low-risk PE up there in the green, then it goes directly in anticoagulation. We don't really spend a lot of time. But if it's a submassive or a massive, especially if it's a high-risk submassive, using the European guidelines approach, we convene an electronic meeting of all of the folks involved. And here's an example of a go-to meeting that is coordinated by my fellows, or the critical care pulmonary fellows, and we leverage that low-cost available modality of GoToMeeting, and send around emails and pages, and saying go to a meeting in 30 minutes or 20 minutes or 15 minutes about a patient that we've just seen with PE. And afterwards, we discuss it, and we come up with a consensus decision about what the best treatment is for that individual patient, based on guidelines and our own knowledge base that we've developed. We described this in a couple of articles in Chest and Hospital Practice, and we started getting calls from all over the world, all over the country at least, asking, what are you guys doing? That's a really cool idea. We'd like to do the same thing. So a year ago, we launched a consortium. At that time, we expected about 15 centers and about 30 providers, because that's what we thought had been calling us. We ended up with 40 institutions and 85 people in a room like this who were industriously, feverishly working on how to create this consortium that was all like-minded in the way this PERT approach would work. And this year, about yesterday, we had our second annual meeting. We had over 130, 140 people in this room, representing about 80 institutions. There are another couple of hundred people at home who couldn't make it. So this is our definition. This is what my talk is. How do you define it? A pulmonary embolism response team is an institutionally based multidisciplinary team that has the ability to rapidly assess and provide treatment for patients with acute PE, has a formal mechanism to exercise a full range of the treatments available, medical, surgical, and endovascular. And if you don't have the surgical treatment, for example, in-house, at least you have the ability to access that quickly for your patients. And you can provide appropriate multidisciplinary follow-up of these patients, and collect and evaluate and share data about the outcomes. So what about that 37-year-old guy who had knee surgery? He had a clot in transit that we noticed on our CTA, and we were planning to extract that based on the PERT call with a vortex extraction catheter. And the team was assembled in the cath lab. This is around midnight, and I can tell you that the patient suddenly, precipitously decompensated, wanted to urinate before we went upstairs, went to the bathroom, and crashed. Blood pressure went down to 0. He was on CPR, and we rushed our team down from the cath lab because we had assembled them, because we had the PERT call, because we had actually done all the preparation. We were able to very quickly crash him onto ECMO while CPR was ongoing. We had him on there within 5 minutes, and it was used as a bridge to definitive therapy. 2 days later, he went to the operating room and had this clot extracted. And I saw him literally 2 weeks afterwards in the office, walking around and doing fine. And he's now 3.5 years out and is doing great. This was an example of how the PERT concept can actually have an effect. I can tell you that in the 400, how many calls? 650 calls, Chris? 650 odd calls that we've had over the past 3.5 years. I think every one of our team members would agree that this concept has actually profoundly influenced the way that we manage pulmonary embolism at Mass General Hospital. And those of you, I don't know if this is true in Barron as well, Nils, but you can speak to this. I think it probably has affected the way that pulmonary embolism is managed there. It's a way to use those guidelines and apply them in individual situations and modify them. So it's also potentially a way to look at some of these new therapies that are coming down the road, novel anticoagulants, ultrasound-facilitated lysis, Vortex and ARI, Penumbra, other ways to extract clot, and whether ECMO, which is now playing an increasingly important role in saving lives for patients with pulmonary embolism, whether this will have an influence, and how should we integrate these into our existing therapeutic modalities. So as an overall perspective, I think in the era of rising healthcare costs and limited resources, it's really time to get serious about evidence-driven therapy in pulmonary embolism, and that will require systematic collection of high-level, clean data that will enable us to develop a comprehensive and believable evidence base, which requires collaboration and cooperation across disciplines, caring for pulmonary embolism, and team-based care, I believe, will provide the optimal decision-making and therapeutic benefits for our patients. In the setting of the consortium, we hope to better understand pulmonary embolism. We have a lot to learn. There's a heightened awareness. I think it's an under-recognized and undertreated problem. And the pulmonary embolism response team is a model type of program of interdisciplinary collaboration that enables us to streamline and optimize care. And this national PERT consortium, which is gaining enormous momentum, and now international PERT consortium or international collaboration will, I think, enhance the knowledge base that we can bring to the guidelines writers so that we can get it right as we move forward, even better, even more right. So thank you very much.